today we are going to give you certain tips and tricks as to how you can maximize your practice and preparation so that you can appear for the part 3 that is going to be held in May 2024. But before I move further, big congratulations to all of you who've cracked your part 2 this time. It's a huge achievement because it is the most difficult part of your MRCOG journey. And you can rest assured that your knowledge is up to the mark. All you have to do now is practice thinking and talking like the people of Royal College. That's it. Okay. So without any further ado, shall we start? Anusha, can we start now?
Yes, ma'am.
Okay. So I think we already have a few participants here. And as we move forward, I'm hoping more will join. So welcome, everybody. I'm Dr. Priyadharshini, and I have been a mentor at Study Medic for almost more than 2 years now. And I hope that by the end of this session, you would have some clarity as to when and how you can appear for the exam. But we are all hoping that you're going to aim for the earliest when your knowledge and your confidence is at its best. Okay. So you know that action is the key to all success, and we are really happy that you have joined us today because that says that you are eager to take this forward. So we have an agenda for this session, and we're going to talk about what is the curriculum, how many are the number of attempts of MRCOG Part 3 by which you have to clear this, how many stations, what is the format, what are the kind of tasks that you are going to get, what to read, of course, how you can succeed, and what are the reasons commonly that students fail. And then we're going to do some activity. So I will be asking for 3 volunteers, and I hope that you are going to be keen to volunteer because it's going to be hugely beneficial for all of you. So you might all be knowing already that these are the Part 3 dates which have been taken by the college for this year. So 8th and 9th May 24, 13th and 14th May 24, 6th to 7th November 24, and 11th to 12th November 24. Part 3 May venues have already been declared, and they are in India, Chennai and Delhi. And in the rest of the world, it's Malaysia, UAE, London and Singapore. And your booking will start on Thursday 29th. Although they have given us a long time, but usually we've seen whatever happens on the first day, and the booking is completed in the first day alone. So you would have to make the best of the first day. How many days do we have for the first date of our exam? Okay, so that's 88 days. So if you are aiming for May 8th and 9th, then that's what it is, 88 days to go. And these are the modules that you are going to be tested on. So we are going to have 14 modules: teaching, core surgical skills, post-operative care, antenatal care, maternal medicine, management of labor, management of delivery, postpartum problems, gynecological problems, subfertility, sexual and reproductive health, early pregnancy care, gynecological oncology, and urogynecology and pelvic floor problems. The types of tasks that you are tested upon, they are going to be 2 kinds, either a simulated patient or colleague task or a structured discussion. Now, by simulated patient or colleague task, we mean that you're going to have a role player. So the role player patient is always an actor or an actress who has a ready-made script and who's going to help you out by the constant questions and the explanations, everything. So here you have to, simulate your OPD. So basically, when you see patients, the way you talk to them, that's how you're supposed to talk to these people. Of course, there will be a little difference in the way we interact depending upon the country we're coming from. But you will all have to learn how to speak to the people of UK and NHS, okay? And where we say simulated colleague task, that means it's usually a teaching task. you teaching an audit, or you teaching a risk management scenario, or some practical thing like an instrument or knot tying. So there, of course, the difference will be that in a simulated patient task where you're supposed to use only layman's language and no medical jargons, in a colleague task, you are allowed to use all medical language. When we come to a structured discussion, so a structured discussion will be only a discussion between you and the examiner. And all structured discussions are clinical scenarios, and there will be questions, usually around 4 to 5, which will be asked to you one after the other, and you would have to, answer them accordingly. Usually the simulated patient or colleague task, the difficulty that people face in this is the time management, because they are not sure how much time to spend on each of the divisions. However, in a structured discussion, the difficulty that people face is never time management, because everyone finishes in 7.5 to 8 minutes. But what they face, the difficulty is how much to speak, okay, and how to speak, how to be organized. There will be a total of 14 tasks. So it's one after the other. Each task, you will have a 2-minute reading time outside the cubicle, where you're going to be given a set of candidate instructions. These candidate instructions will give you a clinical scenario. It's going to give you a lot of information, and your your organization and situational awareness capacities are going to be checked then and there, because you have to extract all the information from those candidate instructions. Of late, the candidate instructions are quite lengthy, so they're around 2 to 3 pages. So the first thing that you have to practice is to read fast, okay? So that would come with practice, don't worry, we've all done it. And also, once you go inside the circuit, inside the cubicle, the candidate instructions again going to be pasted on the table. So you don't need to worry that if I've forgotten, I don't have any place to look into and recapitulate. They're going to be right in front of you. But you would have to make it a habit to try and remember. Why? Because they don't take it too nicely if you're constantly looking down and not looking at them when you're speaking to them. Okay. So that's something you would have to get into the habit of. You will be tested on 5 domains, which are patient safety, communication with patient and their relatives, communication with colleagues, information gathering, and applied clinical knowledge. Okay. You will not be tested on all 5 domains in all the circuits or all the stations, but a maximum of 4 and a minimum of 3 domains are always there. And the total time taken for the entire examination, which means 14 tasks, is around 168 minutes. So that's like 12 minutes into 14. And there is no break. So please remember, it can become tedious. So that is why we always encourage you to appear for one mock circuit before you go in for this exam, so that you have a complete, exposure to what it is like on the exam day. Okay, because you have to continuously go from one cubicle to the other without a break. There are no breaks. Okay, so what are the examiners like? So you have one clinical examiner, and that clinical examiner, so in every cubicle that you enter, there will be one person who is a clinical examiner. No confusion regarding that. There will also be someone called a lay examiner, who will usually be in 4 out of 8 simulated patient tasks. So a lay examiner is always a part of a simulated patient task. This lay examiner is a non-medical person, and this lay examiner has almost 4 marks in his or her hand. And you can get those 4 marks by being 2 or 3 things, which means you cannot be judgmental. You cannot be, what should I say, paternalistic, which means you cannot say, I recommend or I think you should. And you cannot react, which means suppose a patient is demanding something completely illogical. You cannot say that, what you're saying is completely wrong. You cannot say that it is very unsafe. You should not think like this. So they are just testing you to see whether you are not only whether you're a safe doctor, but whether you are an empathetic person, whether you are a person who knows that there might be things that they are saying wrong, whom you try to counsel and tell them that this is not the way to think, but in not those words. So you have to be very, very polite in this examination. Even if you feel a patient is saying utter rubbish, you cannot tell that to the patient. You only have to say that I understand that you're anxious or you're worried, but I would just want to tell you why I think that this is not a safe option. And then you just tell them why you think so. And then the patient gets to decide what they want to do. Just because a patient is saying something illogical or, taking a decision which you feel is not safe, it does not mean that you disrespect their autonomy. That is how NHS works. So please remember that. So that is what a lay examiner does. The lay examiner just sees your way of communicating. Of course, she or he sees your safety levels. So when you say that it is not safe, because that's how the lay examiner knows that this is a safe doctor. And also how you're taking information from the patient. Are you asking multiple questions at the same time, confusing the patient? Are you continuously talking and not letting the patient talk? These are the things that a lay examiner sees. Okay. When you enter a station in the examination, these are the 3 ways that one station can look. So there may be 3 people, there may be 1 person, or there may be 2 people. If there are 3 people, it means 1 is a role player, 1 is an examiner, and the other is a lay examiner. So you have to be very, very wary in this particular task. Why? Because you know that these are tasks where there's a lot of things at stake. Those 4 marks that the lay examiner is going to give you, you can totally get it just by being polite, nice, kind, empathetic. Okay, please remember that. When you see 1 person only, that means this is a structured discussion and nothing else. And when you see 2 people, that means 1 is a role player and 1 is the examiner. So this is a simulated patient or colleague task, okay? Not necessarily a simulated patient task. It could also be a teaching task where this is your colleague, a junior trainee, okay? How many attempts do you have? You have a maximum of 4 attempts to pass part 3. In case you're not able to clear, you would have to sit the part 2 again. But please don't worry. When I say this is just to make you wary. Most of our students pass at the first go. Of course, there might be some people whose date was not that day, and they might require a second attempt. So please just don't worry. It's just to tell you that these are the number of attempts because you need information at the end of the day. So how will you start your preparation? Of course, your first point is to start with guidelines, right? However, the difference between reading the guidelines in part 2 and part 3 is here, each time you read a guideline, you would have to keep in mind, is there a clinical scenario that can come from this? Because clinical scenarios always come from either guidelines or TOG articles. There is nothing else to come from, okay? So when you're reading the guidelines, you will have to try and extract points which can form a clinical scenario. For example, if you're reading the guideline on placenta previa, you would be looking at, when are we going to deliver this patient? If there are risk factors, when? If there are no risk factors, when? What are the prerequisites? How are we going to counsel? What are we going to do if the patient comes in labor and we don't know the placental localization? What are we going to do if the patient starts bleeding? Because these are all clinical scenarios, either in the form of a structured discussion or in the form of a simulated patient task. So you may get a patient with placenta previa at 34 weeks who's come to you to understand how she's going to deliver. So you would have to know how to counsel her, what we are going to do for her, what extra things, what are the safety things that we have to look into, okay? There are a lot of part 3 books on the net, and there are a lot of stations in there, okay? So my advice is that is a, that's a place where you can start from just to get an idea what a station can look like, or how role players are given a script if you have not had any touch with that as of now. And you have to start somewhere. So don't think, okay, I have a lot of time, first let me read. No, it doesn't work that way. So today, if you're reading, say, early pregnancy, today is your day for reading early pregnancy, you've read all the guidelines, or if at least revised all the guidelines, Then try and go to the module of early pregnancy in one of these books and pick up at least 3 or 4 stations. It could be a mixture of stimulated patient task and structured discussion. And try to do those. You have to start somewhere. So try to do those, keeping your timer from day one. Please don't think, let me practice and then next month I shall start with timer. No, that's not how it goes. You have to start from day one. The moment you start practicing is with timer and nothing else. Okay. And when you come very close to your exam, if you don't do 10 stations per day, you might not be able to revise all the exam test stations before you go for the exam. And that is what gives you confidence. Okay, I have done all the exam test stations. There's just going to be a little tweaking of each station, but I still know the way I should speak for this particular station. Okay, that's where the confidence comes from, with practice only. The third point is a very, very important point. I mean, I cannot stress upon this enough, because when we studied both ways. We tried doing it all by our own. So there are people who are very hesitant to take on a study partner because they may be on different time zones. They may be having very, very difficult and hectic schedules, and they think that, they won't be able to keep up with another person. But trust me, you will always find somebody if you make an effort. So what we used to do is we used to have 2 or 3 study partners. Even if they're on different time zones, we can get hold of someone sometime, right? So if that is feasible for you guys, then very good. If not, at least get somebody, because lots of people think that, I can do a simulated patient task myself where I will be the role player and I will be the candidate. But what they always realize when they sit down for a session with us is that what they are doing is that they are trying to help themselves when they are their own role player, right? So they're talking minimum, they're saying yes to everything, they're agreeing very easily. However, a role player is not like that. A role player has been given a script. So if the role player script says be a difficult role player, the role player is going to be difficult. So if you find a difficult role player, it's not because she or he is a bad person or an rude person. The script demands that, because they are going to test you on that can you get around a difficult patient? Can you counsel a difficult patient? So if you keep a role player, a friend or a colleague who acts as a role player, then the practice is better, because you will realize that a role player actually talks quite a bit. They are there to help you, but if you're going off track, they are going to get you on track by talking quite a bit. So you will have to allow the time, and that is where you fall short of time when you don't practice with a study partner. Okay. Get in the habit of talking. So you, in your region, wherever you are practicing, you're in the habit of talking in your regional language, not necessarily your mother tongue, wherever you're working, the regional language of that place. However, for all of us, or most of us, English is a foreign language. So to get fluency in that, the only way to do it is by talking. You will have grammatical errors. This is not an English language examination. They're not going to judge you on that. But the fluency comes only with talking. You would not have to sit and think at that point of time, how am I going to form this sentence? Don't get to that point where you would have to think about how to form a sentence and not be able to concentrate as to how I will counsel this patient medically. Okay. So get in the habit of talking. Suppose in the initiation of your practice or your preparation, you do not have anybody. Get hold of anybody. It doesn't matter. It can even be your mother. If your mother understands a bit of English, if your mother can speak 2-3 lines of English, it's good enough. If it's not your mother, if it's your partner, your husband, your kids of 10, 12 years who can, at least talk back, just tell them that this is what you're supposed to speak and get into that. Okay. Nobody stand in front of the mirror. Talk to yourself. Why? Because that's when you understand that when you forget something, do you look skywards? Do you suddenly close your eyes? Do you frown? Do you grimace? These are the things that a lay examiner is going to check. They don't want you to do that. They want you to have a passive face. They don't want surprise, fear, judgment on your face, because then you alienate the role player. Okay. Another very good way is record yourself. Just record yourself and then rerun that record to see what did you do wrong? What was your facial expression? What was your body language? Is it acceptable to you? If it's not acceptable to you, it will not be acceptable to the role player. Okay. So these are the small things that you can start doing. Never, never forget TOG articles. Okay. There are multiple instances where lots of stations have come from TOG articles. And when the first time that came, obviously there was a lot of hue and cry. People were near to tears. So again, like in part 2, you did last 3 years of TOG. This time also you will have to do last 3 years of TOG. But of course, there are certain TOG articles which are only theoretical. Less chance that things will come from that. More chance that the TOG articles where there are lots of practical information, clinical scenarios, those will come, okay? Of course, the exam tested stations will be there, but those are, have already been in the circulation for a long time, so it's easier to get hold of those. Give equal weightage to practicing both the SPT and the structured discussion, okay? Because they are equally important and each of them have to be dealt in their own way. And please, please, please do not just read. I know you've just come out of part 2 and you're still in the reading mode, but this is not about reading. This is about extracting maximum information for your reading and then practicing it and putting it out there, okay? Please understand, if you don't start practicing today, you will never get around to that. Okay, so on the exam day, you have to be so fluent that it will feel that you're just talking to a patient in your OPD. Do you sit and think what I'm going to say to a patient who is going to get TLH done 2 days later? You know how to counsel that patient. So that's how it's supposed to be. It's just another day in your OPD. The only difference being is we just talk a little differently in that particular scenario. Okay. And book at least one mock circuit before exams to get the real feel, because what happens in these mock circuits is they are exactly like the actual exam. So you will have 14 stations, one after the other. You will have examiners, lay examiners coming from different parts of the country. And you will get feedbacks in the mock circuits, which you do not get in the real exam, obviously, but that then helps you improve. And you will get role players who are crying and laughing and demanding and angry. You will get all of them. So you know exactly what to expect that day and you're not overwhelmed on the exam day. And lastly, this is really, really important, guys. We have often been asked during our sessions and when we are conducting classes and when we are mentors for certain groups, do I have a template for this on our library that we have, in our study sessions? Please do not memorize templates. You guys all know how to take history because that's what you've been doing for donkey's years, okay? You don't need to understand how to take history. All you need to understand is how to take pertinent history. But please remember that for the last almost 3.5 years, since the online examination started during COVID and also after that, we have constantly been seeing old scenarios twisted to make it a completely new one. For example, we have had people coming and telling us, I got a patient with an ectopic pregnancy whose beta HCG level was, above 5,000, but the patient kept demanding medical treatment only and did not want to hear about the surgery because one of her friends died on the OT table. Now that is something new, right? So then you have to tweak it accordingly. So if you have memorized a template, you will not have situational awareness, which means you will completely disregard that she is not interested in listening to the surgical management and you will waste your time telling her the surgical management. So do not memorize templates. Templates are to help you to know that you haven't missed this particular point. It's not there to help you how to mug up and, express everything, because everything in that template may not be important for that particular scenario. So please don't memorize templates. There are n number of templates on the internet, YouTube, or wherever you go, okay? But it really does not work that way. How to succeed? So on that particular day, you have to look confident, obviously. If you are nervous, if you are constantly looking upwards, twiddling your thumb or, fidgeting, that's body language where you're going to be marked down on, okay? Always be a safe doctor. What do we mean by this? Now, some people do interpret this wrongly, thinking that, being a safe doctor is wherever I don't know something, I will always say, I will refer you to my consultant. No, that does not mean that you're a safe doctor. Then you may be marked down on your applied clinical knowledge if it is something that you're supposed to know. Okay. Safe doctor means you know which particular choice of a patient can be accepted, how long can it be accepted, when to give her recommendations saying that it is not safe and giving her reasons why it is not safe, when to stop certain medications, start certain medications, when to properly refer a patient to a particular specialist. Okay, that is what it means. Of course, I have told n number of times this particular thing. If there is anything, for example, you were very thorough with percentages and recurrence rates in part 2 because those came very frequently. But while you're practicing for part 3, you may not be, you may forget. Of course, there will be some very common things that you have to remember. Apart from that, suppose a patient tells you that, doctor, what is my chance of having this in the next pregnancy? And you've forgotten. You may remember that it is very high or it is very low. You can tell her that, but it is absolutely fine to tell her that I cannot remember the exact number as of now. Why don't I get back to you with the exact number after I've gone through some literature? That's absolutely fine. It's much better than just making up a number and telling her. Please do not do that. If you don't know something at all, you can tell the patient, I am not aware of this particular thing. Why don't I discuss this with my consultant and get back to you? Yes, you may be marked down upon your applied clinical knowledge, but you will gain on your patient safety. Please remember that. Be logical and organized. This is very, very important when it comes to structured discussions, because in structured discussion, what the examiner wants to see is, why is this doctor advising a particular test? Does she know why she's advising this particular test? Can she explain why she's advising this particular test? And does she know how to reach her diagnosis or management by including or excluding certain things, right? That's where your organizational skills come into play. So why I say that structured discussion is an arena where you can show your knowledge is, suppose you say, let's say, where you are suspecting that, you have nicked the ureter, okay? So you are thinking of an indigo carmine dye. You will have to tell why, okay, right? What do you want to see? Because please remember, in NHS, every test that you do for the patient is free. The government is going to support you in that. So therefore, they are very, very particular about proper channelizing of their funds. So you cannot give them n number of tests, but not be able to explain why you are telling that. So if you are suspecting someone with sepsis, you have said serum lactate, you would also have to say, so if the serum lactate is above 2, I would be suspecting sepsis. Okay, something like that. You would have to talk like that. Okay. And when you're asked, how would you reach a diagnosis, you would have to talk about starting from history to examination to investigations, and therefore you've reached this particular diagnosis. That is what logical and organized means. Situational awareness. What do we mean by that? Like I gave you an example of the methotrexate. The other thing is that suppose you are, you've taken charge of the labor room, and you have been called from the A&E saying that I have this patient who I think, the junior trainee is saying, who I think is in suspected ectopic because she's complaining of, amenorrhea, pain, so forth, so on and so forth. Do you go rushing to the A&E? That's where your situational awareness comes into play. You look back and you see that in your board, they are saying that there is a patient who the midwife has come running to you and says, I think this is a suspected rupture. Please come and see. So what are you going to do? A suspected rupture is definitely an urgent scenario, not a suspected ectopic if she's not in a collapse state, which means she's a, ruptured ectopic, where again, you're going to take help of your consultant. So this is what we mean by situational awareness. That does this person know how to handle a particular situation or prioritize a particular situation? That is exceedingly important in this particular examination. Please remember. Okay. Be empathetic and sympathetic. That's how you be a good doctor, right? You are like that in your personal interaction with your own patients. So why should it be different with these patients who are role players? Okay. So yes, that is very, very important. And that is more important in particular scenarios. For example, a patient in chronic pain, a patient having, maybe an IUFD, or a patient whom you're giving a history of, a diagnosis of a stage 4 ovarian cancer, all these things, right? Use simple non-medical language. Be polite, be non-judgmental. Very, very important. Medical jargons will bring your mark down in communication with patient. Okay, because obviously the lay examiner will not understand anything. So therefore, lay examiner says, if I can't understand, the patient can't understand. So there she is going to deduct marks. And B, the patient is going to constantly interrupt you and say, sorry, doctor, I did not understand that. So you lose out on time also. And time is a very, very important thing. 10 minutes and not a half a second more also. The buzzer is going to go and you have to get up from that seat because your next colleague has already come into the cubicle. Okay. Be an active listener. So guys, please listen to the role player. The role player actually is there to help you. So if a role player is constantly harping on a particular line, she's continuously asking you a question, stop, listen, answer that question. Then and there, even if it means that you're in the middle of your information gathering and you have stopped to give a part of patient safety or a part of communication with patient, and then you just go back to information gathering. That's absolutely fine. But obviously, the role player is anxious about something or very keen or curious about something. And so just remember, it's the role player's agenda and not your agenda. That day, the role player is the most important person because she has, again, a lot of marks. She has 2 marks in her hands. She just needs to tell at the end of the station, this doctor was a safe doctor. I would like to go back to this doctor. Okay, I have done the RCOG circuit. That's how they take feedback from the role player. Do you want to go back to this doctor? Did you feel comfortable with this doctor? Did the doctor explain everything that you wanted to be explained? That's it. These are the 3 questions asked. And if the role player ticks all the boxes, you get the role player's 2 marks. Okay. So please remember that. Always, always listen. What is she saying? Is she saying something that I was not habituated to hearing or I did not expect to hear? Then please stop in your train of thoughts, which means you are going wrong and the role player is trying to get you back on the right track. Okay. Don't think that, okay, why is she saying that? No, I will just continue with the template that I had memorized. No. Then that means it's a different scenario because there is something written in her script which demands that the question be answered. Okay. Leave the mistakes of the previous station. Guys, among 14 stations, it is not possible that 14 out of 14 is going to go top notch. You will think, oh my God, I did such a brilliant station. Not possible. Not possible for even the person who's going to get a gold medal in MRCOG Part 3. Believe me. And always remember one thing. We continuously tell you one thing. You do not fail a station. You fail domains. So if you feel you've done a little badly in patient safety, say by mistake, you did not talk about IV cannulation or blood grouping and saving in a twin pregnancy in labor, you failed that station in patient safety. Definitely, or you've got borderline. So 2 borderlines is very difficult to make up. But if you've understood that, oh my God, I forgot that, it's all right. Try to make it up in the next station. But do not continue with that feeling in the next station because neither the examiner nor the role player knows in the next station what you did in the previous station. So they are not going to judge you on that. They have no preformed notion about you. They're only going to judge you on how you have performed in that station. Okay. So just start fresh because you don't want to dupe that station also. You don't want to mess up that station also, right? So forget about the previous station. It's done. It's gone. Concentrate on the next station and try and do 100% in that station. Okay. What are the reasons that people fail this station? This exam. Little or no practice. Again, because you're fresh out of part 2, lots of people make the mistake of thinking, I'm just going to read the guidelines which pertains to this clinical scenario and I will be able to speak. You will not be able to speak because when you have to speak, an entire station where you have to counsel, take consent, please the role player, be on the same page as the role player, take information in just 10 minutes. It's difficult. It is not an easy task. It will only come with practice. And by practice, I mean daily practice. It's not, okay, I have had a very hectic schedule today, I'm not going to practice. Even if it means you get time to practice one station, please do it. Something is better than nothing. So start tomorrow by practicing one station. It doesn't matter. It's going to be horrible in the beginning. If you record yourself, you're going to listen to yourself and saying, oh my God, what did I just say? Did I really speak like this? What am I talking about? It's all right. It's all right. Everybody of us did the same thing. Nobody just started on the first station and they were like 100%. Oh my God, I cannot even touch this station because she's so good. That's not going to happen. If someone's telling you that, they are lying about it. Okay. So please start. Start tomorrow, but start practicing. Don't think that this is an English language test, which means they're not going to just, test you that, oh, this patient is very friendly. This doctor is very friendly. She uses the right words. She knows how to thank the patient, take consent from the patient. No. They're also going to test you on your knowledge, right? Because you have structured discussion. Even when there is no structured discussion, even when there is a simulated patient task, they're going to test you on your knowledge. Telling a patient how the follow-up of a molar pregnancy is going to be done is knowledge, right? So it's both. You are going to be tested equally on both places, communication as well as knowledge. Many people make the mistake of using medical jargons because it comes so easily to us, right? It comes very easily when we say placenta, hemorrhage, but these are not terms that the patients understand. Even if there is some patient who is really well-read, has gone through n number of YouTube videos, doesn't matter. You don't need to know that. You need to know that it is after birth and it is excessive bleeding after delivery, which is postpartum hemorrhage, okay? Collecting too much study material. Okay, so there are people who think, okay, I will collect whatever there is on the internet before I start practicing, because then I will not fall short of material. Please don't worry. You can do it on your way. Number one. Number two, everyone has a different way of teaching. So if you are keen on following a particular group, I would suggest that you follow that group only. Because if you follow too many groups, different mentors have different ways of teaching. And you stand to, get confused. It's not as if there is any right way or wrong way of doing a thing. The absolutely wrong way, everyone knows. But how to go about a station, there may be different, ways of doing it. And none of them are absolutely right or absolutely wrong. It's a very relative thing. So therefore, try to reduce your confusion, because this can be a very overwhelming thing. We're not sitting and studying. We're all working at the same time. Trying to find time between your work, family, everything else is very, very difficult. But we are all going to do it, okay? Relying on ready-made templates. Again, guys, I am constantly stressing upon this. Please do not think that you can get a template and mug it up and you're going to be done. It's not going to work that way. Believe me, we've all done it. We've all fallen flat and again got up and redone it, okay? Not believing in yourself. Guys, please understand, you guys are super because you have already passed 2 parts. And these 2 parts were exams which were difficult, which was of a different country, but you still managed to pass. It doesn't matter how many attempts, really doesn't matter. So you are good enough to pass the third. You are always good enough. Don't ever doubt that. Don't ever say, my English is not fluent. Am I good enough? Yes, you're good enough. Like I said, it is not on your English that they're going to judge, because then all the foreign graduates would have failed, because half the time you can't even understand what they are saying. For example, there are a lot of African countries who speak French, so their English is not good. And that's not their fault. That's how it is. But trust me, they don't judge you on that. Not believing in yourself and lack of self-confidence or overconfidence. Overconfidence, oh yes, I have passed part 2. I know all my GTGs. So this is not really that difficult task. No, that's not going to work, because this again is a different kind of exam. Okay. The difficulty level over here is different. It's not about mugging and memorizing concepts or information. It's again a different scenario altogether. So therefore, believe in yourself, have confidence that you're going to be able to do it, but at the same time, work towards doing it. It's not going to help if you're going to get up at the nth moment and say, okay, now I have 1 month in hand, I'm going to do everything. You're going to be overwhelmed. You're going to stress your brain so much that you're going to forget everything. Okay, so start tomorrow. Okay, now let us come to the domains, what it actually means. Information gathering, basically history taking. However, this history taking has to be free of jargons. It has to be very fluent. It has to be concise, because in every station, you have to keep your history taking to 3.5 to 4 minutes maximum. There are certain modules which are a little lengthy. There, maybe you can stretch it to 4.5 minutes. Otherwise, you'll never be able to finish the station, because always remember that out of those 10 minutes, 8 minutes is yours. 2 minutes is the role players. Because the role player is going to talk in between. She's going to give you history. She's going to tell you about how miserable she's been because of her symptoms. You have to give the role player that time. You can't be thinking, oh my God, she's taking my time. Please let me cut her short and give my part of the discussion. You can't do that. That's rude. That's being very, very rude and impolite, and they're going to mark you down. And also in history taking nowadays, there's a lot of history being given already in the candidate instructions. So please do not repeat those. You can, of course, confirm those, saying that I can see that, you are O positive. And she will say, yes, doctor, I'm O positive. That's absolutely fine. But if you ask her again, is it O positive? There will be certain patients who will say, isn't everything given? My GP said she's going to write everything on the letter that she's written. And that's why you're again marked down. Okay. In structured discussions, remember, history taking also means, information gathering also means examination of patient, investigations required, and every information that you've gathered from the candidate instruction, because examination is going to give you some information, right? Investigations are going to give you some information. So that is why information gathering in a structured discussion also means examination and investigations. And what are your sources for information gathering? The NHS information leaflets, the patient information leaflets, they are very, very good. You must go through every station that you do. You must have already read the patient information leaflet to start with, okay? Because that is where you understand what are the layman terms that are used for all the medical jargons that are in your head. And there are a lot of people who have done YouTube videos on how to talk to a patient, how to take a history for a particular thing, what not to miss. So you can go through those also. Applied clinical knowledge. Of course, all your applied clinical knowledge is going to come from your guidelines, your scientific impact paper, your TOG articles, okay? All of those. Patient safety. Now, this is an extremely important domain, guys. I cannot stress how much important this is. And there are a lot of people making mistakes in these. So confirming that this patient is the patient whose reports you have. So name, age, and they have a unique NHS number. So confirming that. Their BMI, their blood group, reservations for blood transfusion, which means are they a Jehovah's Witness? If it's a Jehovah's Witness, do they have advance directive? Allergies, very, very, very important. There will be stations where allergy is one of the main important factor that the patient is going to be talking about. Or there will be a scenario where a patient is allergic to something, which is probably the key medication that you usually use in a particular disorder. Okay, so remember, allergies is very important. You cannot forget this. You may forget anything, but you cannot forget allergies. Safe medicines. Smear history. Again, smear history, very, very important in patients with vaginal bleeding, be it pregnant, non-pregnant. Okay. Alcohol, smoking, recreational drugs, because you're supposed to refer them to particular departments. So stop smoking services. You're supposed to talk to pregnant patients who take alcohol regarding fetal alcohol syndrome. So these are all patient safety points. Mental health. Very, very important in the NHS scenario. Okay. So proper referral, the impact of mental health on certain scenarios and certain clinical disorders, very, very important. And proper referral. That is what makes you a safe doctor. You know, this is my domain, and you know, this is where I need to send them to my colleague who's going to look after her better. Okay. So WHO says that patient safety is a framework of organized activities that creates cultures, processes, procedures, behaviors, technologies and environments in healthcare that consistently and sustainably lowers risks, reduces the occurrence of avoidable harm, and make error less likely and reduce its impact when it does occur. Okay, that's what patient safety means. It just means that you're able to keep your patient safe in whatever clinical scenario it is. Okay, and even if some harm is caused, you know exactly how to intervene so that no further harm is caused or it is not repeated in another patient. Okay, that's what we mean by patient safety. Okay, communication. So what does communication entail? It starts with your proper intro. Please remember, this itself has marks, okay? Where you introduce yourself, how you introduce yourself. Are you smiling? What is the scenario? And whether you're smiling or you have a somber face, like for an IUFD scenario, you will not start with, hello, I am so-and-so. You will say, your voice will be less jolly. It will be low-key. You will have a lower pace, okay? All of that. Explaining your role and purpose of consultation. Establishing a rapport. Very, very important, because you want the patient to tell you everything, even if there is a hidden agenda. Patient should feel so comfortable with you that she will want to tell you whether she is being abused by her husband. Has she ever been sexually abused by someone in the past? Is she on antidepressants? Is she traumatized because her mother committed suicide? All these are scenarios. They're all hidden agendas. Okay. So you are the one who has the potential to take this out from the patient by just being friendly, by telling her that I'm on your side. Please remember that. Concise, relevant history taking by asking open-ended questions. What do we mean by that? So the best way to reduce on your information gathering time is asking the patient, can you tell me more about what you've been going through? And the patient is going to tell you everything. Instead, suppose a patient comes with excessive, comes with menorrhagia, and you ask her, for how long have you been having the bleeding? Is it very heavy? How many pads are you changing? Each of these are questions that you're asking, for which the role player is going to take 10 seconds to answer. So you add up and your 4 minutes is gone, right? So therefore, ask the role player to tell her problem, so that she has told you most of it, and whatever she's not told you about the information gathering, you can just fill in. So if she's told you everything and when it started and how she's been suffering, all you have to maybe ask her is whether there's any history of postcoital bleeding or intermenstrual bleeding, or is there any severe dysmenorrhea? Maybe she missed out on that. Okay, so you reduce the number of questions you ask. However, you would have to also ask closed-ended questions. So it should be a mixture, but mostly open-ended. Empathy, active listening, following the patient's agenda. Very, very important, guys. It is not your agenda. It is not that I have come here, I have to finish the station in 10 minutes. I have to ask these questions. No. You may have to stop. You may have to repeat. You may have to listen, because the patient does not want to hear what you're saying right at this moment. The patient wants to hear something else. Okay. So then you please stop. You stop and tell the patient what she wants to hear. It doesn't matter if you have left out one point on information gathering. You will have to just come back. Managing communication barriers, which means what? You see an African name, or you see an Arabic name, or you see a name which is, it says that she is an immigrant. The first thing that you have to ask her is, are you comfortable in English? They will always be comfortable in English. Please understand that this is an examination, but they will not get another person as an interpreter to sit with you. It is understood that she is comfortable in English, but when you ask that question, it shows your situational awareness. It shows that you understand that there are people with different kinds of needs. You get marked on that. So you ask, are you comfortable in English, or would you like to arrange, would you like me to arrange an interpreter for you? You have done your job. You've got that 1 mark. Okay, it's done. And you can just continue in English. Don't feel scared. Okay, what if she says, no, I need an interpreter? She will never say. But this is a question you have to ask if you feel that this is a person whose mother tongue is not English. Please let me ask. You will get Indian names also. There also you will have to ask. Giving information in chunks. So you can't just say the entire procedure of total laparoscopic hysterectomy like, she's been doing TLH every day. You have to give her 2 lines and ask her, have you understood? Or am I clear so far? So we always say that if it's a simulated patient task, you have to minimum call out the patient's name 5 times, and that is giving info in chunks, because otherwise how will you understand that am I giving information in chunks? Okay. So you have to talk about just the entry, how you're going to have, a small nick on your belly button, and then maybe there'll be 2 more nicks on the either side, and we are going to put in instruments. Am I clear so far? And then you go on to say what you're going to do in the rest of it. Okay. Again, after the procedure, you say, am I clear so far? Then you say what to expect post-operatively. Okay. That's how it's supposed to be. Checking understanding, which means, am I clear so far? Being polite and respecting patient's decision. So a patient wants VBAC and she's saying that I want to do a home delivery, doctor. You do not say that's such rubbish. You can't have home delivery. It is rubbish. I agree. But you cannot say that. Or you cannot say, no way can you have a home delivery. It is totally unsafe. You cannot start your statement like that. You have to say, I understand that home is a very comfortable situation to deliver in. However, research has shown that home delivery in a patient who's had a previous cut on the uterus is not safe. Let me tell you why. So you have accepted that for some reason she wants a home delivery, but you have also told her why it is not safe. You have respected her decision. Not necessarily you have agreed with her decision. They're 2 different things, okay? Encouraging dialogue and shared decision making. So you are giving her enough information so that she can decide. So that is what shared decision making is. You do not say, I recommend, I suggest, I think you should. You just say, because there will be instances when the patient says, so doctor, what do you think I should do? What do you think is the safest method that I should choose? You cannot say, I think this is the safest method. You will have to say that for scenarios where there is not absolute contraindication. Okay. What you have to say is, I have given you all the different modes of management, and I will also give you certain information leaflets to support our verbal discussion. And you can take your time in discussing with your partner or your family members and come back to me whenever you're ready. So you've given her all information, but it's now the ball is in her court and she has to decide. Taking informed consent with special attention to ascertaining mental capacity. Very, very important, guys, because you will get young girls who has come to you wanting contraception, wanting surgical termination of pregnancy. So mental capacity is very important to ascertain. You have to test her by telling her certain information, telling her to repeat that information, understanding whether she's actually fit to go ahead, understanding that if you don't go ahead with her wishes, is she going to cause herself self-harm? That's what mental capacity ascertaining mean. And also, there will be scenarios where there'll be a demanding mother who will come and say, how dare you give my daughter contraceptive pills? Don't you know that she's a young girl? So you're telling her, okay, you can have your many number of boyfriends. It doesn't matter. I'm giving you contraceptive pills. We've had scenarios like that. A mother demanding and telling you that you do not know your job. You are not trained enough because you have given a young girl contraceptive pills. So that is where you have to explain to her what mental capacity is. So you have to know what mental capacity is, okay? Ensuring the use of chaperone for intimate examination. Guys, please understand that you are not needed to examine any patient over there. There is really no scope for that at all. However, there may be certain scenarios which might, tell you that an examination is going to help you further. For example, a patient with chronic pelvic pain, you would want to tell her that I would like to examine you and maybe take swabs at the same time to rule out any infection. And I would like to do it in the presence of a chaperone, because it's an intimate examination. A chaperone has to be there. A chaperone is basically a person, and is usually the nurse over there or the person who's helping you out in the OPD, who comes and just stands so the patient feels comfortable. Okay, because there may be male doctors, there may be female doctors, whatever the sex of the doctor, doesn't matter. Chaperone is needed when you're doing a per speculum and a per vaginal examination. Okay. Be sensitive to the culture and religious issues, which means, suppose you're dealing with a patient of genital mutilation, you know that it in UK, it is considered illegal. And you will, of course, tell that to the patient also. But you will not judge her for having a female genital mutilation in whichever country she's come from. She can't help it, right? Her religion and her culture dictated that some people just got it done on her. So that's what I mean. So be very, very sensitive to that. There will be scenarios where you are going to get malformed babies, congenitally defective babies, where the mother says, I'm a Catholic and I'm not supposed to be aborting. So tell me, what are my other options? You cannot tell her that, there's no hope for this baby and therefore I actually recommend that you should get a termination of pregnancy done. No, you cannot tell her that. You will have to be very, very respectful of her religious beliefs. Okay. And you should tell her alternatives to it. Okay, guys, any questions so far? I'm checking your understanding after a very long time because you guys are all medicos. So please tell me, any questions so far? Anyone? No, I'll take that as everyone's understood everything and move forward. So now we are going to get on to the activities. I would like 3 volunteers, please. And very quickly, because there are 3 stations. And please do not be scared. Every one of you, there's none of your friends sitting here are going to judge you. They're all on the same page, believe me. We just want to start somewhere. We want to tell you that this is how it is done. Okay. This is just a rehearsal of what the actual thing is. So please, can you volunteer? Yes. Naheem, would you like to do the first station? I can see that you've raised your hand.
Yes, ma'am.
Okay, fantastic, Naheem. Thank you so much. Okay. Who would like to do the second station? Anyone? Come on, guys.
Yes, ma'am.
1 second, please. This is, who is the second person who said yes, ma'am?
Yes, ma'am. Ambreen.
Amreen. Okay, fantastic. Who would like to do the third station? Anyone? Guys, come on. Don't waste time. Okay, fine. We'll start with the first station. And in the meanwhile, another person, please get ready to do the third station. Okay. In case you do not want to, because then you will get you will understand how it's going to be done. Okay. So in each of these stations, Naheem and Amreen, we have a scenario for you to go through, which is the candidate instruction. Okay. You will get 2 minutes by the clock to go through this scenario. I will be a role player and I have my own script, which you do not get to see. And once you are done with whatever the tasks asks you to do, I will be giving you the feedback as to where you did correctly, where you did wrong, what you did wrong, and how to change it. And then I'm going to show you the ideal answer to that particular station. Are we clear, Naheem and Amreen?
Yes, ma'am.
Okay. So, Naheem, I will be starting your clock.
Okay.
This is your station. There are more slides for you. So please let me know when you're ready for me to turn the slide.
Okay.
Your time starts now, 2 minutes.
Okay.
You have one more slide, Naeem. Please let me know when you want me to change.
Okay, you can change.
Okay.
You can change the slide.
Those were the two slides. Do you want me to go back to the first one?
No, no.
Okay.
Okay, can you go back to the first one quickly? Okay. Stage performance. Okay, next one. Okay.
Please start.
Okay. Good evening, Miss Lara Cook. Are you going to reply me?
Yeah, hello, doctor.
And I'm one of the candidates taking this exam, and I've been asked by my examiner to ask you some certain questions. Do I have your permission to go ahead?
Yes, of course, doctor.
Okay, I understand that you are 20 years old and that you're a stage performer. Is that correct?
Yes, that is right. I am 20 years old.
Okay, where do you live? Are you married?
No, doctor, I am 20. I am not married, and I live in very close to this hospital.
Okay, what's your highest level of education?
So, doctor, I had to drop out of college because I live all alone. I don't have parents, and I am ballet dancer. So my dance recitals don't really pay that much that I can go through college and look after my daily needs. So I left college a year ago.
Oh, so sorry to hear that. Okay, so when was the last menstrual period?
That was almost 7 days back.
Okay, have you ever been pregnant before?
And no, never.
Okay, so may I ask, what were your complaints? I learned that you were referred by the general practitioner because you have been having pain in your pelvic region. Is that correct?
Yes, doctor, that is absolutely correct.
Okay, can you tell me more about this pain?
Yes, actually, I have been having this pain on and off for the last 2 years. Of late, it has really become very bad. In fact, I cannot do without painkillers at all. But now, of late, or it's been almost 2, 3 months that even the painkillers are hardly working. My GP did give me some contraceptive pills because he said I'm going to do better with them. It was true that I was doing better, but it produced such low mood that I was not being able to get out of bed. I was not going to work. I was missing auditions. So I just stopped them on my own. But the pain is really bad. I'm having a lot of difficulty, especially during periods. In fact, even sex is difficult now. So I just want
Oh,
you to give me a treatment which is going to just do away with this pain.
oh, I'm so sorry to hear this. I will try our best as much as possible to help you. Okay, but I'm just gonna ask further question with regards to this pain. I understand that you have given me some information already. Okay, do you have any abnormal vaginal discharge?
No, doctor.
Okay. You say you usually have pain while menstruating, and is that correct?
I'm sorry.
Usually, the pain,
Yes,
do
it
you
gets
have it
worse during
outside of your
menstruation.
menses as well?
Yes, that is right. It
All,
gets really bad during menstruation.
all right. Do you have maybe have you noticed maybe during your menses as well you have repeated headaches
No, not really.
that only come during your menses? Okay, any bleeding from your umbilicus?
No,
Okay, do you have repeated cough or chest pain, difficulty with breathing that is just limited to your the time of your menses?
no, not at all, doctor.
Okay, so apart from the analgesics and the contraceptive pill, have you used any other drugs?
No, doctor.
Have you done any tests with regards to this complaint?
No.
All right. So I'm going to be discussing the tests that we're going to do in order to identify the cause of this pelvic pain and see how we are going to treat you. Is that can I go ahead?
Yes, yes, of course.
Okay. So there are different reasons why you may be having this kind of pain. It could be endometriosis, it could be pelvic inflammatory disease, and others. So first of all, you have do a scan, a pelvic scan for you in
What
order
is
to
that you said,
check
doctor? Endo what?
pelvic scan. So it's an ultrasound scan of your pelvis.
Okay, and that's going to tell me where is the pain coming from?
So yeah, so that will help us to look at the womb as well as the ovaries. If you have things like a fibroid, it's going to in your womb, the scan is going to tell us about that. If there are any problem with the ovaries as well, like I said, the endometriosis, the scan is also going to identify that. Am I clear?
Okay. Yeah, doctor. Okay. And
Yeah.
if you
So
find the reason that it is in the womb, you can just take out the womb, right? I'm not interested in keeping the womb because I don't need babies or anything. So, and I've heard that, you can just remove your womb and all the pain is going to be gone. So, I am okay if you take out my womb.
oh, okay. Well, that is one of that's an option to take out the womb. However, we have other options also in order to treat this if it is present. If it is just fibroid, we may just remove the fibroid. Okay, but
Okay.
like you said you are not interested in having babies, right?
Mm-hmm.
Okay, so that's an option that can be considered. Although we have other options, like I said, also drugs is also an option. Some injection can be given in order to prevent this pain. Also, we are going to do a test to check, we call it swab test. The test is going to we take like a cotton board into your vagina, and then we take a swab of it and then test if there's any infection that is present. This may also help us to identify the cause of the pain. Am I clear with that?
Yes, doctor.
Okay. Do you have any question for me so far?
No.
Okay. Mm,
I just want to know that if you diagnose what is the problem and if it is all to do with my womb, will you take out my womb? That's all I want to know because I have read a lot of places that if you remove the womb because the pain is coming from the womb, I will be
oh,
free of this pain if you take out my womb. I'm only interested in knowing that.
oh, okay. I understand. So now, because of the treatment that we're going to offer will depend on what you really want. If you want, if you want to understand that you've never been pregnant and you may want to have babies in the future. And so if this is present, then the first option will not be to take out the womb. Okay, so because we have different options, it could be drugs and it could be surgery. Drugs may come in form of pills, which you have already been given, but seems not to be working quite all right. However, there are some other drugs, such as some injections that you can take for 3 to 6 months that may also help with this. Are you following me?
Yes, doctor. But what
Then
if these injections are also the same kind that comes in those pills?
no, they are not the same. They are not the same. They are different chemicals, so they are not the same.
Okay,
as
but
the
are you
pill.
sure that those are not going to cause my mood swings and low mood?
Yeah, so if you take those drugs, the way they work, they tend to cause to decrease the hormone which is present in women that are still trying to give birth, which we call estrogen. So when this hormone goes down, it's kind of mimic that the person is in the menopausal stage. And with that, you may have some low mood, some internal heat,
But
symptoms
doctor,
that
I
may
don't
leak
do
memory.
very well with those kind of medicines because you see, I have a family history of depression. My mom had depression so severe that she committed suicide. So I don't want to take that because that puts me at a risk. So do you
Okay.
have anything else for me?
Yeah, so the other option now is surgery, is operation. The surgery may involve just taking out the fibroid, just taking it out. And then the other option is to take out the womb if you are no longer interested in having babies. Am I clear with that?
Okay. So you are telling me that you first have to understand what the pain is for. You can't tell me now. You don't know why I'm having this pain, right?
No, I can't say until we have done this test, and then I can get more information to you after that.
Okay, that's your time.
Okay. Do you have any other question?
Thank you, doctor.
Thank you very much. I'll also give you this patient leaflet which you can read.
Okay.
And can read more about the condition.
Thank you, Naheem. You did a good job. You covered a lot of things. So, Naheem, the main thing is that when you read the candidate instruction, you have to see whether it's a patient-simulated task or a structured discussion. In patient-simulated task, you're supposed to start with, hello, I'm Dr. Naheem, one of the doctors in the clinic today. Am I speaking to Lara Cook? Okay. There you do not say I'm one of the candidates for the examination and my consultant has said to, take some information from you. Okay. Okay, Naheem?
Yeah, okay, I'm with you. Okay.
Yeah, that's one. The other is that the information gathering when you start, it has to be very organized, which means you cannot start with level of education. I do not know why you started with that, maybe probably to understand how much you can speak to her or how to go about it. But it's all right to start with just her problems first. Okay. What is she here for? So, like you said, can you tell me a little more about what you've been going through? That's absolutely the right way to do it. That's an open-ended question. And she told you a lot of things.
Okay.
One thing, guys, that you must remember for any scenarios where a patient is coming back again and again with something or a chronic pelvic pain, there is one aspect which you have to rule out, and that is of sexual abuse in the past. Because there are a lot of papers which show that any adverse sexual experience in the past may be associated with these kind of symptoms. Okay. Or it could also be that, for example, if you have a patient who's coming back in the antenatal clinic over and over again with vague symptoms, non-specific, and the midwife can't find anything wrong with the baby, with her, nothing, you need to rule out if everything is fine at home. Why does she keep coming back? Does she actually need help and not being able to say so? Okay. Always remember. And how are you going to ask that? So in these kind of patients, you don't just ask that right at the beginning, but once you've set a rapport and once you have gone through her information, when you're taking her sexual history. So it's very important that you take sexual history here, which means you try to take a history regarding STI in either her or her partner. You ask her about dyspareunia. Of course, she told you about dyspareunia, so which is absolutely fine. You also tell her something like, that I want to ask you a question which may seem a little personal, but this might give me some information to help me come to a particular modality of management for you. We have seen a lot of times that these kind of chronic pains may be associated with any kind of abnormal sexual experience or unpleasant sexual experiences in the past. Miss Cook or Lara, do you have any such experience that you would like to share with? Okay. So in her script, she is a patient who was sexually abused by her music teacher at the age of 16. So that is a hidden agenda, which she's not going to share with you unless and until she feels comfortable and confident with this doctor. Okay, Naheem?
Please, I got distracted. I didn't get how to elicit that history of sexual abuse. Can you just please
Yeah,
go
so
over it again?
you just tell her, and once you've taken, you're supposed to say sexual history, right? Which means about STI in her partner, any history of dyspareunia. Okay. And here, when it's a chronic pelvic pain, you just ask her that often we have seen that these kind of chronic pains may be associated or may be triggered by any abnormal or uncomfortable sexual experiences or unpleasant sexual experiences in the past. So, Lara, is there anything like this that you would want to share with me? Okay, that's how you ask her.
Okay.
Yeah. So that's one thing in information gathering. And you are definitely supposed to ask her regarding medical, surgical, and family history. Very, very important. Okay. Why is it that she is having low mood with contraceptive pills? We know contraceptive pills can cause low mood. But is there any risk factor that we have to rule out? Is she an absolute contraindication to contraceptive pills for some reason? Okay. So if you were asked me about family history, I would have told you, why am I alone? I said I live alone. So you never asked me why I live alone. Okay. So living alone, 20-year-old, is an issue. It is a social security issue. It is something where you have to look into that. Does she need further help? Does she need to be liaised with the social services? She said she's dropped out of school, college. She's barely making ends meet with her ballet classes or whatever she's doing, her occupation. Okay. So this is where you become a safe doctor by trying to help her do better in her life, because she's all alone at the age of 20. Why is she all alone? I would have given you a history that my father died of cancer last year. My mom died because she committed suicide when I was 16 years. So yes, I have a bad family history. So you have to ask family history. Very, very important. Okay. So for patients, post-operative, antenatal, you would have to ask about VT risk. You have to ask about pulmonary embolism, hypertension, diabetes, all of these. Also, it's very important to ask about smoking, alcohol. Okay, she's a young girl. Is she a chronic smoker? Does she do recreational drugs? Okay. Hello, Naheem?
Yes. I'm
Okay,
with you. Thank you. Yeah, I'm
yeah.
following.
Yes, okay. I told you about my occupation. Otherwise, you might want to ask her about occupation. Why? Because she keeps saying that, she's in a lot of pain. It's affecting her quality of life. So if she is already in a job, you would understand the severity of the symptoms if she's taking off work multiple times in one cycle. Okay. So if her periods are so painful that she's off work for 2 days, 3 days in a row, every cycle, then that's cause for concern. Also,
Yes.
mental health. So you're supposed to ask, have you been down or depressed in the past? However, this is a question that you don't need to ask for everybody, but in a patient of chronic pelvic pain, obviously she is so disturbed, you would want to find out, that is she's very, depressed because of this continuous pain that she's having. However, if it's an antenatal pregnant patient whom you're breaking the news of being pregnant, she's chirpy, she's very full of life and laughing and smiling at you and happy that she's pregnant, you don't need to ask her if she's down or depressed. It's not a mandatory question, but you have to see the patient across you. Is she averting your is she averting your direct gaze? Is she looking down? Is she constantly looking at her watch? Is she shifty, fidgety? That says something is wrong. Okay. So that is why we continuously tell you, look at the role player, speak to the role player, listen to the role player. It's very, very important. They are going to guide you. Support at home is very important, not only for a patient who's this young, also for anyone, an antenatal patient. Why? Because you would want to know that after she delivers, is she going to be looked after by somebody, or do you need to send the community nurse to look after her? If it's an elderly person, I mean, is she in the care home or is she all alone? So then you would want to post-operatively not send her home immediately, maybe look after her till she's stable, send the community nurse along to look into her stitches, look into her welfare, all of that. So support at home is a patient safety point, please remember.
Yes, ma'am.
So in information gathering, you have to start with an open question. You have to elaborate on whatever is the main problem with her. So here it was the pain. The type, the intensity, the duration, aggravating relieving factors, any association with her cycles, association with bowel and bladder. You did ask, I think you were trying to ensure that she doesn't have endometriosis by asking her whether she bleeds from the umbilicus. Well, that's not a very common symptom. More common would be, does she have dyspareunia? I mean, does she have pain during penetration? Is it in the initiation? So that deep dyspareunia is something very suggestive of endometriosis, things like that. Bowel and bladder symptoms. So you're ruling out IBS, BPS. All of these can cause chronic pelvic pain. Associated vaginal discharge. You did ask. Very good. What are the treatments taken so far? You have absolutely asked about that. Well done on that. You did empathize that it is affecting her quality on life. That shows that you are an empathetic doctor. So the lay examiner gives you marks for that. Menstrual history, you did ask her when was her last period, but you could also ask her about any abnormal bleeding that she's facing, like a postcoital or an intermenstrual bleed. Obstetric history, you asked her, has she ever been pregnant before? Very good. Sexual history is very important in this patient. Okay, please remember. So any STIs that can be causing pain. Like I said, dyspareunia, I told you myself. Otherwise, you would have to ask medical, surgical, family history, and social habits, important. Support at home and mental health. Examination, you will tell her that I would like to examine you. You did say that I would like to take swabs, but you would want to tell her that I would want to examine you in the presence of a chaperone to see whether I can find the cause of your pain or I can pinpoint the cause of your pain. I would also like to do an internal examination to see the site of your womb, whether it produces any pain while I'm doing that. And at the same time, I would like to take some swabs from your vagina. And when it comes to examination, there may be certain situations when the patient says, doctor, do you absolutely need to do that? It's very painful. Okay. So you do not say, you can say that it would give me additional information and I would also be able to take certain investigations that I think are absolutely necessary and which would help me come to a diagnosis. But if you see that she's adamant and she's very uncomfortable with an examination, please don't go on pestering her about it. Say, okay, no problem, Lara. What we can do is we can get the other tests done. And when you're comfortable, we can come back to the examination. Okay, you can absolutely say that because that will put her at ease. If you constantly pester her, it will make her very uncomfortable and she will not be able to build a rapport with you. It will make her extremely uncomfortable. When it comes to patient safety, you did not ask about allergies, BMI. That's very important because high BMI has a lot of associations in patients who are going to undergo surgeries, in subfertility. So you would have to make it a practice to ask these. However, you will again have to individualize cases. For this particular patient, it is necessary to ask BMI. Why? Because in this kind of a patient, if you're not getting any upfront diagnosis when you've done an ultrasound or taken swabs, would you not want to do a diagnostic laparoscopy? That is a modality of investigation, right, Naheem? So if it's an operative procedure, a BMI plays a huge role, okay? Because there are certain safety issues involved with high BMI patients, low BMI patients, also when it comes to laparoscopy. Blood group, you would have to know the blood group of the patient. It's very necessary. Allergies, absolute must. You cannot forget allergies in any patient unless and until it is mentioned in a candidate instruction that she's not allergic to anything, okay? Social habits, which I mean drinking, smoking, and recreational drugs. Okay, so when you talk about social habits, you would have to signpost, which means I would like to ask you about some lifestyle, lifestyle. I would ask to ask some lifestyle questions. Are you okay with it? And then go forward. Okay, you can't just start asking, do you smoke? Do you drink? No, you can't. History of sexual abuse, like I said, how you're supposed to put it, that is a patient safety point, because it may be a patient, who had a history of sexual abuse. She was too scared. Over here, of course, it's a very old one, but it could be a recent one also, which started off the entire thing. She's so scared that every sexual encounter is painful for her. So a sexual abuse history has to be taken very sensitively. You would also have to ask at the end of it, would you like me to help you with pressing charges against the person who did this? Because she may not have been able to go to anybody, and she may need help, and she may need closure in that. She may need someone to tell her that I'm here to help you to go forward with this. And you are the one who's doing that. That's very, very important. History of depression and suicide in the family. So she has already started feeling low, not only because of her pain, but also when she has contraceptive pills. Does she want to go to some expert who would probably try and help her with it? She may require certain medications. You don't know about that. Support at home. Stepwise management. This girl kept saying, I want my womb to be removed. Just because she says, I don't want babies in the future, you don't say that that is an option. Because all of us know that just the removal of the uterus will not help if it's an endometriosis. She would also need her ovaries removed. So you would have to tell her that everything stems from the ovaries. And if I remove your ovaries at such a young age, you're going to have menopausal symptoms, and that can be really harmful for you. So you would have to emphasize on the fact that we would like to do alternative therapies. But before that, we would like to diagnose. And lots of times during the diagnostic laparoscopy, we might find reasons why you are having the pain and be able to treat at the same time. You would like to burn those endometriotic nodules. You might want to do some adhesiolysis. So you would have to explain to her that we might be able to find a solution even while we diagnose. So communicating here, communication with patient is very, very important. This will be a lay examiner task, definitely 100%, because she has so many things where we tend to judge a person. She has history of mental health issues. She has history of dropping out of college, of sexual abuse, of chronic pain, not being able to be with her boyfriend because she has dyspareunia, a lot of things. Okay, she is a troubled 20-year-old. Empathize with her pain. Tell her, yes, you are not imagining your pain. It is real. So, like Naheem said, I'm so sorry that you're going through so much problems, that you are in such a difficult situation, that you are acknowledging that it is affecting her quality of life. Be open and honest, because you said, yes, I don't know what the diagnosis is, but I will find out. I will try and find out. But you will also have to tell her that even when you have done the diagnostic laparoscopy, you may not be able to tell her what is the cause, because all of us know that almost in 1/3 to 2/3 of patients, we might not be able to tell, right? Okay. Give info in chunks, check understanding, which Naheem did. Offer information leaflet. Yes, he ran out of time, but he started with it. Support groups. Guys, this is a very important part of the NHS system. There are a lot of support groups for every disorder or derangement that happens to people. And you must offer them support groups. So how do you introduce support groups to them? You don't say, I will liaise you with support groups. You tell them that there are a lot of people like you who are suffering from similar symptoms, and they have formed some groups which are present online, and I will give you information regarding those groups, because sometimes talking to people who are going through similar things often helps for you to understand your situation better. You have to explain to them what a support group is. You can't just say, I will liaise you with a support group, okay? Does she want assistance in reporting the sexual abuse? That's very important over here. And psychological counseling. And because you got a letter from the GP, communicating back to the GP regarding what you've done, how you've gone across with it, what is it that you have done for her, and how you have given her treatment, and from where the GP is supposed to continue has to be told to the GP. Okay. Applied clinical knowledge is the entire guideline, guys. So MDT input, this is very important. Chronic pelvic pain is supposed to be handled by a multidisciplinary team, which consists of your consultant, the gynecology medicine physician, the pelvic pain clinic, the specialist nurse, a counselor, a social worker, a physiotherapist. A social worker is important in her place. She's a 20-year-old with no support system. A counselor, because she might require help with her mental health issues, and a physiotherapist, because a lot of time, pelvic floor, suppose she has just dyspareunia. So there a physiotherapist comes in, okay? Investigations, yes, Naheem, you talked about swabs to rule out STI, talked about a scan. And you can tell her that we might require higher imaging modalities if the scan does not tell us something. Diagnostic laparoscopy, you have to talk about it. You have to talk about how that can also help us in the treatment, but you would have to tell her about the risks. Management, very important that you tell her about the pain diary, because you want to know exactly what kind of a pain it is. So you want her to maintain a pain diary and come back to you after 3 cycles. And in the interim, you can start her medications. Analgesics are the first line, but she's told you that they're not helping her much. And she's also told you that COCs are not helping her and she's having low mood. So you talk about alternative pills, which Naheem said. Other treatments will be as per diagnosis. So you can't rattle off endometriosis. Naheem, you would have to tell her, if you're going to talk about endometriosis, you would have to tell her what endometriosis is. So my suggestion in this kind of a station is, if you have not already diagnosed that she is having endometriosis, then you don't need to go into the details of the diagnosis. But if she says, what do you think, doctor, what can it be? Then you can say that, there can be different things. It could be, of course, a tumor in your womb. It could be some problems where, there are certain, the lining of the womb is also getting shed outside and therefore it's causing problems. Or there can be certain web-like structures inside your womb, which is leading to these pains. Because you do not ask surgical history, she's had a history of appendicectomy, although that's not something very significant. But then again, any surgery can produce adhesions. So that is where the significance of this comes into play. Surgery, when she talks constantly about removal of womb, you will have to tell her that I understand you are very troubled with your pain, and I understand that you've read that removal of womb will help. But please understand that we will also need to remove ovaries, because that's where the hormones come from. That is how. Hello. Please mute yourself. Guys, all those who are not taking part, please can you mute yourself? Aisha, can you please mute whoever is speaking? Yeah, so you would have to talk about risks associated with menopause when you remove ovaries at her age, and also explain that surgery is a major thing and it itself poses risks. Okay.
Okay.
Any questions, Naheem, or anyone else from this, or we'll move on to the second station?
Yes, I have questions.
Yes, Naheem, please tell me.
So I think, thank you so much for the opportunity and the feedback. So I think this
and thank you for taking part. You are a brave soul. Tell me.
Thank you, ma'am. Okay, so it's like a 2-in-1 question requiring us to take history as well as do some counseling for the patient. I think that's what got me confused. So now, if I've gotten to the counseling aspect and I remember some history, is it advised I go back and ask those questions as well?
Yes, you can. Yes, absolutely. Absolutely. So I'll tell you, I had a BPS station, bladder pain syndrome station, and I completely forgot to ask her about her coffee habits. And it turned out that she used to take 15 cups in a day. So that is a very significant history in BPS. And while I had started on her differential diagnosis, I suddenly remember and I said, I'm so sorry, but I have one information that I forgot to take from you. Do you take coffee very often? And she started laughing and said, oh, I love my coffee. I can't stay without it. So had I forgotten, I would have lost a mark in both the management option, because I had to tell her to refrain from too much coffee, and also information gathering. You are absolutely free to go back and take anything that you suddenly remember was significant you haven't taken. The only difference it will make, it will not make any difference in any of the domains. There is something called a global score, which at the end of each station, the examiner is supposed to give you on his, what should I say, impression about you as a doctor in the NHS. That can suffer a little, because the examiner might think, okay, this doctor is a little disorganized, but which is fine. The global score does not affect your passing and failing. The domains do. So if you think that this particular thing in information gathering was very important, for example, early pregnancy, vaginal bleeding. If you have forgotten to take cervical smear, that's patient safety point. You've lost out on that. You've lost a point. So please go back and ask about cervical smear history. When was it last done? Was it normal? It's very important. Okay, you can go back. Anything else?
Okay. Yes. So I was a bit I don't know how to put it eventually, because you kept on saying that you want the womb removed, and like in the other lecture, you said that you still need to listen to the patient. Like the example that you gave, that beta ECG was 5,000, and the person said that she wants a medical treatment
Right.
instead of
So you were confused as to why you should not agree with her surgery, right? Is that what you're saying?
Yes.
Right. So see, like I said, so this station that I talked about, the medical management patient, that was my station 2 years back. Okay. So I did tell her the medical management, but I also told her red flag signs. I told her you need to talk to your partner. If you can't, I will. And I will also explain the red flag signs, because if you are supposed to pass out, lose consciousness, that means that you've had a rupture. You need to come back. So I have done safety netting, which means I have told her what she wants to hear, but I've also told her why it's not the best option. So when you tell a patient that the option that you're asking for, I am telling you the option. But I'm also recommending, but not saying that I'm recommending you by giving you reasons to not choose this option. So when you tell her, I can understand that you're not interested in having babies. That is completely your decision. And I can also understand that you're so upset or troubled by this pain that you're more than willing to remove the womb. But Lara, I just want to tell you that the pain does not stem from your womb. It actually stems from either ovaries. They understand what ovaries are. So you don't need to think that is a medical jargon. It stems from your ovaries. So not only would we have to remove your womb, we would also need to remove your ovaries in order to make you pain-free. However, if we remove your ovaries, then the main hormones or main chemicals that are secreted in your body, which is responsible for your mental health, the health of your heart, the health of your bones, and your general well-being, will fall and become zero. And you are going to have adverse health consequences because of this. And you are too young to be suffering from those consequences. And also, what you're asking for is a major surgery. And surgery has its own risks. So would you like me to tell you about certain other modalities of management that we do have in place for women who are suffering from symptoms such as you? So you have told her that I am okay to go ahead with your removal of womb, but I'm not okay because of these reasons. And when you tell her her heart is going to suffer, her mental health is going to suffer, and her bones are going to suffer, do you think she's going to jump into it? Okay, no, I still want my womb to be removed. No. Right? No. So basically, you're supposed to be manipulating her. If you want me to use a very, very mean word, you're supposed to manipulate her because you're the boss over here. Please remember that. Okay? Okay. Anything else?
Final question. How do I ask about BMI?
I'm sorry. How do you ask about
BMI?
BMI.
BMI.
Do you know do you know your weight by height ratio? They know weight by height ratio. They're supposed to know. Okay. That's a simple question. Yeah. Okay. Anyone else with any questions for this station? Otherwise, we'll move on to Ambreen.
Can I just ask a question, please?
Yes, please. Yes. Go ahead.
Yeah. So if we want to ask about BMI, can we just tell them that as a part of your examination, we'd like to just check your height and weight?
Absolutely. If it is not given in the candidate instruction, you can first ask whether she knows her BMI, because that's a simpler thing, because she might just tell you her BMI, because that might be in a role player instructions, that when the doctor asks, please tell your BMI is 23, 24, 25, whatever. If she says, I'm not aware of your BMI, then you can say, no problems. When we examine you, we will also check your weight by height ratio. That's absolutely fine.
All right. Okay, thank you.
Right. Anything else? Okay. So, Amreen, are you ready? Let's move ahead with your station.
Yes, ma'am.
Okay. Give me a second here. That's yours. Your time of reading starts now.
Okay.
You have 3 slides, Amreen, so please let me know when you want me to shift it.
Okay. Yes, ma'am. Next slide. I don't know what this birth plan is. That is the water birth.
Which one, dear? Are you not being able to read it?
No, I am saying this slide, but
Huh.
I
So there are
been
different things written. Just read it. I'm not supposed to be talking to you. Whatever you want to
yeah.
interpret from it.
Okay. Next one.
Please start.
Yes, ma'am. Me, Amreen, one of the doctors today in the antenatal clinic. May I know your name and age, please?
Hi, doctor. I'm Eileen Johnson and I'm 34.
Okay, nice to meet you, Alan. Can I call you Alan?
Yes,
How are
absolutely.
Okay, how are you?
Yeah, I'm doing absolutely fine, doctor. Thank you for asking.
Okay, Alan. I have just read your information leaflets, and I have come to know you have previous one cesarean section, and you are now 36 weeks pregnant, and you are here to discuss the mode of delivery. Is it okay, Alan?
Yes, that is right, doctor.
Okay. Let us start, Alan. May I know what's your plan and what are your expectations?
So, doctor, like you may have noticed that I have got the birth plan with me and I want all of these followed meticulously.
Yes, Alan. Uh, I just review the birth plan, and I think you are interested in normal delivery after cesarean section.
Yes, that is right, doctor, because I have gone through a lot of internet and YouTube videos, and they say that almost 8 out of 10 women can have a normal delivery after a cesarean. So my last experience was pathetic. It was traumatizing, and I don't want to go into the hospital anymore. And I want to stay at home and deliver under my midwife. But my midwife still said that I have to come and talk to you. So here I am.
Okay, Alan. You are right. You have read the things that are okay. You have thought rightly. Home is very good place for delivery. But I want to discuss with you a few things more. Can I know more about what was the traumatic experience and what happened?
So, doctor, actually, last pregnancy, that was like 4 years back, I had a completely normal pregnancy, and I was told by the midwife that I can have a home delivery. So everything was going fine, but I think I was around 5 centimeters dilated. when my midwife said that my Joshua's heartbeat, that's my son, Joshua's heartbeat is falling.
Okay.
And immediately I was transferred in an ambulance to the hospital. And there they immediately hooked me up to all kinds of machines. I don't know what they were. I was not able to walk. They had some needle in my arm. Then there was this big circular thing on my tummy, which just did tuck, tuck, tuck. And I was hearing my baby's heartbeat. And then there were people running around. The labor room was so busy. And, there were people screaming and shouting. And I think it was a junior doctor because she looked hopelessly young. She came and told me that my baby's heartbeat is not settling. So therefore, it's best that I have a cesarean section. And it was so confusing. I was so overwhelmed. I could not even understand what was happening. But I just, at a first time mother, I was scared. So I just thought, that, okay, fine, whatever is best for Joshua. So I went ahead with the cesarean. I hardly got any explanation of what they were doing, why they were doing. Post the delivery also, I did not have a problem, neither did Joshua, thankfully. But no one really came forward to tell me what happened and why it happened. So this time round, I really don't want to be a part of this circus. I want to be at home. I want my husband, my son to be with me, and my midwife is fantastic. So I have no problems. I'm not coming into the hospital.
Okay, okay, Ellen. I am sorry to hear all about your problems. But thank God you and Joshua were all right at the end of the operation. How many?
Yes, that was really reassuring.
Yeah. How many years old Joshua is?
He's 4 years.
Okay. Ellen, let me tell you a few things about your delivery and how was your antenatal period up till now?
Everything was
Any?
absolutely fine, doctor. Even my last ultrasound, as you might have noticed, is absolutely fine. They said the baby's grown normally and everything is fine.
Yeah. I have reviewed that, but I want to know, had you any medical problem, comorbidity like high blood pressure or anything with your sugar level?
No, doctor. Like I said, it was absolutely fine. No, absolutely normal.
Okay. Let me tell you a few things more, Ellen. As you said, previously you were in the labor and suddenly Joshua had disturbed heart and you were shifted to the hospital and cesarean was done, operation was done and both of you were fine, although you were confused and about the hospital environment.
That is right.
Yeah. Okay, Ellen. Let me tell you now your pregnancy a bit more complicated than before. That was the first delivery. Now you have a previous surgery. A few problems arise during delivery when the previous surgery is done, like yours, in which one among the 200 ladies can experience rupture of the uterus. That is a very horrible. The womb would rupture, God forbidden, and that may cause very much, that can endanger your and your baby's life. So in such cases, yes, Ellen. And in such cases, doctors don't advise to deliver at home. The best way to deliver is at the hospital under the consultant. I will arrange your meeting with my consultant, and also I want to tell you, I will uh, uh, I will explain. Sometimes the labor room is very busy. You were already um, worried and you felt all the such things. However, it doesn't happen always. I will guide you to a good place. Our hospital is a very good place to come for, and you can come before the surgery and you can have some familiarity with the hospital and the doctors and the environment. You wouldn't feel that one, and it doesn't mean you would always have a operation afterwards. You can deliver, but this normal delivery should not be in the home. That should be in the hospital under the supervision of a consultant.
But doctor, as soon as I enter the hospital, you're again going to put all those machines and I won't be able to move about. I really want to move about because I have read that when ladies are mobile, they have higher chance of normal delivery. I really want normal delivery this time.
Yes, Ellen, you are right. in the hospital, we will, as you have a previous surgery, we have to again monitor the fetal heart, like tuk tuk you said before, and also we have to attach the monitor for the problems discussed already with you. But we will do our maximum effort to keep her up on the bed, and sometimes you can have mobility in the labor room. And also I will, if you like, I would refer you to the counselor, and that will help you to release the anxiety related to the previous experience. If
Okay,
you would
fine,
like,
doctor. But I
I
just want to know that whether you can follow the other parts of my birth plan. Maybe I'd love to have a water birth, and I don't want any medicines, or I don't want the continuous examinations that they do, from the vagina. I don't want all of that.
yes, yes, Ellen. We are with you to support. We wouldn't have so much examination. Examination will be done after every 4 hours, not before that. However, my opinion will be, you have to deliver in the hospital environment, and you can get a few visits before the final decision, so that you may become more familiar with the staff and with the hospital environment, with all the other things. Then your anxiety will be much lessened. And also, if you want, I will arrange your sitting with the counselor, and that will also help you.
Okay, doctor, but you're sure I can have a water bath, right? I've really read a lot about it.
Yes, Ellen, water bath is something good, and many people have a good experience about that. But again, we are worried about your previous surgery. In water bath, the continuous monitoring that you said, the tuck, 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 that would not be able to do that. And that is a necessary part of our monitoring. And okay, you have time to think about this again. I will give you leaflets, and to read at home, and we will further arrange a meeting 1 week afterwards with the consultant, and perhaps you will be much more comfortable after talking to her.
Sure, doctor. Thank you so much.
Okay, Ellen. I'm going to arrange your sitting with the consultant after 1 week. Can I do?
Okay, thank you.
Thank you, Ellen. Okay, see you again.
Thank you, Amreen. You did a really, really good job. And
Thank you, ma'am.
and you are a doctor who is very, very pro your own hospital. So your hospital will be very proud of you. Our hospital is a lovely place to deliver. Yes, I'm sure it is. Okay. So, Amreen, always remember, not only Amreen, everyone who's here, always remember that your candidate instruction, each and every page matters. Okay. So if your candidate instruction has something like a birth plan given, you would have to discuss a little about it, even without the patient asking or saying so. So, for example, when you talked about home birth, why it is not safe, very good. Spontaneous birthing start. You are agreeing on this, right? VBACs, you would want them to have spontaneous labor. So, like you have not agreed with this, if you agree with something that's on the birth plan, she's going to feel a little happy and she's going to be a little encouraged. Okay. Natural water release. So you can say that, we would artificially release the water only if we feel that you are not progressing in labor. When she asks about water birth, you can tell her that yes, initial period, you can have a water, you can be in the water, because we do have waterproof telemetry. You know what telemetry is, right? It's a cordless
Okay.
CTG, the probe. Okay. So yes, we do have waterproof ones, but however, when you are ready to deliver, because certain problems can happen during that time, we would want you to be on the delivery table and not in the water, because we would not be able to diagnose it then and there. Okay. When she talks about free movement, again, I'm sorry. When she talks about free movement, tell her that we have cordless attachments. So even when we are hearing your baby constantly, because that is really necessary in order to understand whether anything is going wrong with your scar, but you will be allowed to move about freely, not a problem. Okay, like she said, dim lights, soft voices. These are things that you can totally agree with. Okay, so you can tell her that we are going to try and keep the noise to a bare minimum, the people to a bare minimum, so that you don't feel overwhelmed, so that you are comfortable just like you would have been at home. You know, you are reassuring her that although she's had a really bad experience, you would not want her to go through it again. You understand that this is a very sensitive time and you are totally supporting her. However, certain demands that she is making is not for her safety, and therefore you cannot allow that. But you cannot tell her that I cannot allow her. Just have to say that, you know, this is why I cannot allow her. And she's going to decide on her own that, yes, it is not safe for me and my baby. So I will not go through with it. Okay. That is how it is. Again, you are manipulating her to think wisely. That's what you're doing. That's your task. Okay.
Okay.
Right. So when you take information, very important, guys, whenever you're talking about or you're discussing with a person who has had a previous surgery, be it a cesarean or be it anything else, it's very important to ask two questions. Number one, how was your recovery post the delivery? Of course, I told you that my recovery was fine. And number two, I would like to review your notes with your permission, just to see that there was no problem during the surgery, and also to see what kind of a cut was given on your womb. Okay, because if it's a classical cesarean section, she's a no-no,
Oh.
right, for VBAC. So you are ruling out contraindications for VBAC from her previous notes or even from asking her. I mean, obviously, a patient is not that knowledgeable that she's not going to know what a classical cesarean section is, but she might be able to tell you, yes, my doctor told me that the baby would not be able to come out, so they had to, cut me further, things like that. Okay, they're going to tell you in their own terminologies. History of present pregnancy, you asked, very good. So if a patient has already told you, I have had no trouble so far, leave it at that. Don't waste your time with information gathering, asking her, did you have high BP? Did you have blood sugar? No. Then she would have told you, yes, I'm taking blood pressure medicines, or yes, I am taking diabetes medicine, I'm taking insulin, whatever. That's what she's supposed to do. She's not going to hide it. That's not a hidden agenda. Okay. History regarding medical, family history, personal history. Why? Because that can have an effect on her pregnancy time, right? Patient safety, again, allergies. Guys, you cannot forget this. Allergies, allergies, allergies. That's your first patient safety point. Even in your sleep, you should be able to ask about allergies. Blood group, reservation for blood transfusion, BMI, exploring patient's concerns. Yes, you did ask her what went wrong. So she told you exactly why she's so fearful of having a hospital delivery. Very good on that. You have to rule out contraindications to VBAC. So how do you rule it out? You asked her whether she's had any problems in this pregnancy. You saw her latest ultrasound. You asked her about her previous recovery and what was the indication for her cesarean. So you know that she does not have contraindications to VBAC as of now. Informing about complications. You only told her about scar rupture, but you could also tell her about PPH. You could tell her about operative vaginal deliveries being higher. Okay. You did tell her about delivering in consultant-led unit. That is a very important patient safety point. And you told her about her continuous monitoring. You also have to tell her that we would want you to. So that is one of the preconditions of VBAC, right? Because it says very clearly in the guidelines that in case you need to induce or augment, it has to be through the consultant only. You cannot decide on that. So therefore, you would have to tell her that all said and done, the success of your delivery, normal delivery, would also depend on whether you go into labor yourself, because that is the optimum scenario, because we would not want to give you medicines artificially to start your pains, because that is shown to cause more incidence of the scar giving way. Do not say womb rupture, just say the scar, the previous scar can give way. They understand that language. Okay. Okay. And when you come to communication, how do you greet Amreen? You don't say me, Amreen. You just say, I am Dr. Amreen, one of the doctors in the clinic today. And may I confirm your name and age? Okay. Or you can say, well, I'm one of the registrars in the clinic today. And may I confirm your name and age? Okay, Amreen?
Okay.
You assessed her concerns. Very good. You do not use a single medical jargon. Excellent on that. You gave her info in chunks, but I did not hear you asking, am I clear so far? But that is very important when you're giving her information. Respecting her wishes. Yes, you said, yes, home is a nice place to deliver. And I can understand that you had a traumatic experience. It's very good. Non-paternalistic approach. Nowhere did you say that I recommend or it is not safe, statements like that. You said that it is recommended that you deliver because of this, this, this. So you told her the recommendations and you supported it with the reasons. That is exactly the way you're supposed to do it. You talked about the fetal monitoring. You talked about risk of rupture. When it comes to applied clinical knowledge, Amreen, you would have to touch about elective repeat cesarean section. Although she has said, I want vaginal birth, there is one question that you can ask her. You can tell her that, Amreen, in case you do, Eileen, in case you do not go into labor yourself, the other option is having a repeat cesarean section. Would you want me to elaborate on that? Or would you want me to give you information regarding that too? And she may be adamant, no, I don't want any information about another cesarean section. I just want to know about vaginal birth. Stop at that. Do not go on with the elective repeat cesarean section, okay? But if she says that, doctor, then what is the point? If I can't have a normal delivery, you're saying that the success is less and you're not going to give me medicines, then I might as well have a cesarean section. So please tell me, what are my advantages if I have a repeat cesarean section? So that is where you have to elaborate, okay? And for VBAC, like I said, you would have to tell her about the pros also, not cons only. That's very important. You are, you are supporting her in her wish to have a VBAC. Why? You talk about the success. You talk about shorter stay, faster recovery. If she wants to become pregnant, so it's a very good question to ask her, what are your future fertility plans? And she may say, I want 2 more babies. And then you say, then of course, vaginal birth is an excellent option because then it puts then you put yourself at lesser risk in the future pregnancies. Okay. So she wants to hear from you that, yes, she's taken a good decision. She's taken a wise decision. You need to support her on that. That is how you build the rapport. And that's how she's going to come out with every information that she has in her script. Okay. And you reduce your time of information gathering. So you talk about the cons. So you talk about rupture, the assisted vaginal deliveries, the sphincter injuries, and the transfusion risk. And in baby, the slightly higher risk of hypoxic ischemic encephalopathy. How do you say that? In layman's term, you just say that your baby may suffer from less blood supply during labor. That is slightly higher in people who are trying for a vaginal birth after a cesarean section. And elective repeat cesarean section, you talk about the pros, which means that she knows the time of birth. But however, in spite of that being in place, she might just go into labor before that, and then you're going to individualize. So you say that at that point of time, we're going to examine you and see which will be the safest option for you. And cons, you talk about in the future fertility, what are the problems? So adhesions, placenta previa, in infant, you talk about increased problem with breathing just post-delivery, and you talk about certain cuts on the face when the baby is being taken out, which is very minor, and it can be in the range of 2 in 100. Okay. Any questions?
Yes.
Amreen, anyone else? Any questions? No? You need to know this chart, guys. Very important. But I've just put down all the salient points in that I shared with you. Okay, that's it. Okay. Nothing else? Okay, so who is... Yes, please tell me, Amreen.
No, ma'am, it's okay.
Okay, fine. Thank you so much, Amreen. Thank you for volunteering. I want another volunteer, otherwise I'm going to call out random names. Anyone? Soumya Singh. Who wants to... Yes, is someone volunteering?
Yeah, I can do it.
Who is this?
Sindhu.
Okay, fantastic, Sindhu. Thank you so much. Okay, just give me a second, darling. That's your station. Please start. You have 2 slides. Let me know.
Yeah. Can I see the next slide, please? Okay.
Please wait. You still have time. If you want me to show you the first slide, I can just do that.
Can you show me the second slide, please?
Yes, sure. Please start.
Yeah. Hi, I'm Dr. Sindhu. I'm one of the doctors in clinic today. Are you Miss Zarina?
Yes, that's right, doctor. I'm Zarina Maqsood.
Yeah. Am I okay to call you Zarina?
Yeah, sure.
Yeah. Can you just tell me your date of birth and address just for confirmation?
I'm sorry?
Can you just tell me your date of birth and address so that I can just confirm it? It's just a necessity.
Okay, so I am 32 and
Okay.
I live in Sussex.
All right. Hi, Zarina. Just wanted to discuss with you. You underwent evacuation for pregnancy loss. You had a couple of weeks back. Am I correct about that?
Yes, that is right, doctor.
Okay. I'm so sorry for your loss. We just have received the report back from the tissue that we had sent off for testing, and I just wanted to discuss the report with you. Is that okay?
Yeah, sure, doctor. Is everything all right?
Yeah, just wanted, you will need some further follow-up. Have you been okay after the surgery that you had?
Well, doctor, I've just been a little upset in the past few weeks, but I'm feeling better now. I am gradually coming out of it. Other than
Oh,
that, everything's been really fine. And my bleeding is bare minimum now. So other than that, physically, I've been fine.
that is very good to hear. Have you, we just have got the report back, and the reason that we sent off the test, I'm sure that day when you had the surgery, it was explained to you. We just want to make sure that everything is okay in the pregnancy that you had. And so when we've sent off the test, it has come back that the report is suggestive of what is called as molar pregnancy.
What
Have you
is that,
heard of molar
doctor?
pregnancy? Right.
No,
So
never.
never. Okay. So when we say molar pregnancy, basically what it means is that it is not really a normal kind of pregnancy. Basically,
What
the
do you
baby
mean?
was, yeah. So basically, the baby was not formed well. And so there was no baby which was formed, but what was there was a lot of tissue which was formed. Obviously, it is like a pregnancy, which is why your pregnancy test came back positive. But because it was not a proper pregnancy, that is why you probably had bleeding, and then you had to have the surgery done to remove the tissue.
So did I do something wrong, doctor? Why did the pregnancy not form?
No, it has got nothing to do with you. It is not your fault, and that's very important that you understand that. It was nothing that you did, or it was nothing that your husband did, your partner did, which has caused this problem in the pregnancy. And it is not something that you could have controlled. But it's now that we know that we know this thing, we just have to take care of. We just need to follow it up so that we can manage the problem.
Okay, so what are you going to do about it? What do you mean?
Right.
Can I have this again in another pregnancy?
Yeah, right. There is a chance that you can have recurrence of this, but the point is for this pregnancy itself, you will need to have a little bit of follow-up. It's very important that you understand that there is a small risk that this can become abnormal, this abnormal pregnancy cells which you have formed can become something bigger. So we need to follow you up for that.
What do you mean bigger?
Yeah. So there is a very small risk of something abnormal happening. So there is something called as that it can become something like a cancer. So we need to
Cancer?
follow you up.
Oh my God, doctor, cancer. I mean,
No,
you mean I can die from this?
no, Zarina, that I'm not trying to tell you that you can die from this. What we are trying to say is when you have molar pregnancy, it is very important that we follow you up and make sure that it is all cleared up before we allow you to have before we say it is okay for you to have another pregnancy. And if it is, that follow-up is important to make sure that all this thing is cleared up from your body.
Okay, so how are you going to follow me up?
Right. So what we would have to do is in UK, technically what we do is we don't, you may have the surgery done in any hospital, but there are 3 specialist centers around us where we would send you to. So at this point, what I would probably first do is I'm going to write a referral letter to our nearest center where we would send them the details of the results that we have received. And then we would have to do a blood test for you to look at the pregnancy hormones to see if pregnancy hormones are still present in you. And then based on what those results, we'll send them to you and they will arrange follow-up for you to come and, to have your follow-up under them.
Okay, so how soon can I have another baby? Can I try in like maybe 2-3 months?
And it all depends on how your pregnancy hormone comes down. So when we suspect, usually when we do if you remember when you were admitted under us, we had done your pregnancy hormone and it was quite high. So that is when we suspect that there may be something abnormal going on. And then we will repeat. Now we have to keep repeating our pregnancy hormone every week till it comes back to normal. So usually by if it comes back to normal by within 2 weeks after your surgery, then we say that after 3 months after that, you can plan on a pregnancy. So I would say safely by around 6 months. If your pregnancy hormone comes back to normal within 2 months, then I would say safely by around 6 months, you can think about planning a pregnancy.
Okay, so all these 6 months I would have to be, giving those blood tests that you talked about.
No, so you will just keep having blood tests till your pregnancy hormone comes back to normal, to 0, which is what we expect it to be. But it is
Okay.
very important that during this time, I know when you were discharged from the hospital, you would have had a discussion about when you can plan pregnancy. But this, just because the histopathology report the report from the tissue has come back like this, we would advise you to delay any plans for pregnancy till you get all clear from that center. So it's important that you use some kind of contraception when you are with your partner.
So, I mean, my husband's not very good with the condom. Do you think I can take something?
I wouldn't advise you to take hormonal contraceptive pills. It is at present. So that may not, till your hormone levels come back to normal, we don't want you to be going on hormonal contraceptive pills. So is it possible for you to convince him to use a condom, or you could use a female condom or something which would help you?
Okay, maybe I have to talk to him.
Yeah.
Okay.
Do you want to come into the hospital and you want to bring your partner in so that we can have a word with him also and make him, so that both of you together can understand and we can give you further information. We can also provide you with some leaflets, and there is a very good RCOG leaflet on this which you can understand about the follow-up and everything.
Okay, so doctor, I'm a little concerned. You talked about cancer. How would I know whether I am having, I am the one who's having cancer? Is it very common?
No, it is very, very, very uncommon. It is very uncommon and it is a very rare thing. And it is also, the cure rate is very high, especially with the kind of molar pregnancy that you had, because you had complete. It's very, it is not a common problem, which is why we follow you up. Obviously, once you are under the specialist center, they will keep following you up. And if say your hormone levels are not coming down as we expect it to come down, then you may need some further investigations to see, if there is any problem, and then we can give you medication to help you with that. But the cure rate is very high, so it is not dangerous like the way I know when we use the word cancer, it sounds really dangerous, but it is not dangerous the way you understand it, and it's got a very high cure rate. So the risk is very, very less. But the only reason I mentioned the word is so that you will understand the importance of the follow-up, especially because you are not going to have follow-up under us, but you're going to have to go off to another center to have the follow-up. It's more difficult for you, which is the only reason I mentioned that. Do you understand that?
Yes, all right, doctor. Yes, I think so. But that was a lot of information. So you did tell me that you're going to give me something to read. Maybe I'll be at a better place when I read those.
Yeah. So if you want, we can even talk to your partner about it, because this is a lot of things for you to take up by yourself. And obviously for you, this is, it's about planning your family and everything. So you can bring in your partner and we can have a word with both of you together also. And at the same time, if you're okay with it, I will start the process of sending off your reports to the specialist center so that they can arrange follow-up for you.
Yes.
Is that all right?
Much.
Do you have any questions for me?
No, thank you so much.
All right. Okay.
Thank you, Sindhu. Your communication skill is really excellent, but please understand that you will not get a second extra to ask, do you have any questions? Okay. So therefore, try to keep your information gathering as concise as possible. The good thing that you did was that you let the role play talk quite a bit and you asked pertinent questions only. However, it's very important to say either of the two. So either you ask her, because she's had a suction evacuation, you can't just assume that her blood group was positive or everything went fine. You would either have to ask her, if it's not given in the candidate instruction, you will absolutely have to ask her what her blood group was. Okay. So in the role player instruction, it is given that her blood group was O negative and she has received anti-D. So if you have missed out on that, then that could be a patient safety concern. Okay. And also the sexual and reproductive health guideline that came out, I think last year, says that the oral contraceptive pills are now safe in patients who are undergoing follow-up in molar pregnancy. The only thing that they cannot use is IUCDs and IUS, and also they can't use fertility enhancing medicines till the pregnancy hormone has come down to 0. Okay, but CHCs are safe even during follow-ups. So that is a change that has happened. Okay. The other thing is just a second, I was going to tell you something. Yeah. So where do you work, Sindhu? Are you in India? Are you outside India? Hello?
Outside India.
Yeah, okay.
I work in the UK.
Yeah, I could tell by the way you were sending her to the GTD referral center. Okay, good. Great on that. Fine. So again, guys, so this is a patient who's come to you for a discussion of the report. So although it does not mention too much in her candidate instructions, you're going to get even more elaborate instructions. But it is all right to take just the very important history. So you could ask her what led up to her miscarriage. And of course, you asked her about her recovery. Very, very important to ask everyone with miscarriages and IUFDs about both their and their partner's emotional recovery. Guys, please understand, if this is a lay examiner task, you're going to be marked on that. Okay. So you'll have to ask her about how she's coping and whether she needs help with coping strategies. Very important. So there could be a psych referral that she might be wanting and she'll feel better about it. Okay. So previous history. So you can just ask in one word any major, medical problems that you've had or any major surgeries apart from the suction evacuation that she's had. Okay. And yes, you did ask her how you've been doing. And she said that I've been down, but I'm doing better now. Very good on that. You have to ask her about her support at home. You have to ask her, how is her husband doing? Is he okay? you did tell her that there's nothing that you or your husband's done, but you still have to find out whether she's doing okay and she's well supported at home. That's a patient safety point also. And since she's in the follow-up period, you could ask her about her contraception. Smear, you may not ask now. It's all right. I have just put that in. Patient safety, you did everything very well except for her blood group. Reservations, you do not need to ask specifically here because she's already had a surgical procedure. Everyone knows that she does not have a reservation, sure. Otherwise, it would have been mentioned in a candidate instruction. Allergies, very, very, very important. Please do not forget allergies. Allergies is something that you have to ask. You cannot presume anything. Okay, Sindhu? Okay, I don't think, yeah. Is Sindhu here?
Yeah,
Okay.
yeah.
Yeah, sure. And red flag sign. So when she's saying, how would I know? Yes, you did talk about the persistence of the beta HCG, but also tell her about whether she's having any abnormal vaginal bleeding at any point of time, difficulty in bleeding that you're suspecting that she's, gone further down the line. Registration, you talked about, very good. Follow-up, you talked about. So you have to tell her that usually it reverts back to normal within so many days. And from then onwards, it's around 6 months that you're going to follow her up. Okay. Can use CHC immediately, but you cannot use IUCD and IUS till the beta HCG becomes normal. In communication, very important to find out how she's coping, how her husband's coping, offering her counseling, post-procedure recovery. You did ask about all that. That's good. When you're giving her this kind of a report, although it's not like breaking bad news kind, but still it's a concerning report. So initiation, you could ask her whether she's alone, whether she has someone with her, whether she wants someone for, just supporting her, whether you want her, want her to be sitting with your nurse, so that just for extra support. You could ask her that. Although you said later on that you could get your husband in because we could discuss with him as well. That's a very good point. Tell her the diagnosis. Now, this diagnosis has to be told a little better. So how would you try to tell her what a molar pregnancy is? So you just tell her that when a baby is formed, both the sperm and the egg gives equal amount of genetic material, so that the baby has equal amount of genetic material from both the mother and the father. However, a molar pregnancy is an abnormal pregnancy, which Sindhu said, where all the genetic material comes from the father itself. That's why the baby is not formed properly, and that's why you miscarry. Okay, yes, there is nothing that you and your husband's done, and there is no control that you have on this, but this is how it is. So you have to tell them what exactly it is, and tell her that why it is necessary to follow up, because it can turn into cancer, and also that even if it does, the cure rate is very high, which Sindhu said. So that is a reassurance for the patient. In applied clinical knowledge, everything to do with the guidelines, of course, the pathogenesis that you've been able to explain to the patient, knowing the importance of the follow-up. Registration in GTD center is both ACK and patient safety, guys. Don't forget, that's a very, very important point in patient safety. What are the implications of rising titer, right? You told her, knowing about the treatment, the success rates, knowing that CHC can be given immediately, because she kept saying that my husband will not be using anything. So if yes, she can start her CHC right away. Knowing about avoiding pregnancy till the follow-up is completed. Yes, you talked about that. And that the recurrence rate is very low, but it can still recur. Okay. Any questions, Sindhu or anybody else?
No, thank you very much.
Thank you so much, Sindhu. Anybody else wants to ask any question regarding this particular station? Okay, guys, so we have reached almost the end of our session. I was not planning on taking such a long session, but invariably it did become long. I hope all of you have not fallen asleep. I can see that there are only 17 past participants from 33. So everyone else has gone around their work. So the last thing is to do with how we can help you in achieving your dreams in passing part 3 at one go. So like I said, that we do conduct live circuits. So we have live circuit 2 days course for the May exam, and they are in different parts of the world. In India, we have in Faridabad, Hyderabad, Chennai, Kochi, and Mumbai, and the dates are given, as you can see. Registrations have already started. The beauty of this particular circuit is that you will get absolutely the real feel of the circuit, because they are back-to-back circuits. There is no stopping. You just go from one cubicle to the other as the buzzer goes. There will be role players with scripts. There will be lay examiners. There will be examiners. The only added benefit in this circuit is that you get a feedback immediately of 2 minutes from the examiner, so that you know immediately how well you've performed and what you need to change in your performance. And these are concentrated for the May 2024 exam, of course. And we also have workshops just prior to the circuit course, where we will be teaching you about the normal labor, the breech delivery, the external cephalic versions, different mid-era insertions, all those practical aspects, okay? And we have these courses. We are starting with the 10 weeks course, and we have already started with a long course. So anyone who wants to avail, the numbers are given below. So the beauty of these courses are that even if you don't find time to practice spontaneously on your own, we are going to force you to practice by giving you every day one activity, which can be either taking history or counseling, or telling the steps of a particular surgery in layman's terms, so on and so forth, depending upon what module we are taking. And those daily activities, depending upon how long your course is. So obviously for a 10-week course, we take short daily activity days and we take sessions more frequently. Whereas in long course and 6 months, since we have a bit of time, we usually have daily activities for 7 days. And at the end of that, your mentor for that particular week is going to take a session where they're going to have 8 stations, where she is going to be the role player, and we are going to have 8 students who are going to be the candidates. And you're going to get feedback at the end of it, and they're going to tell you exactly what went wrong, what you did well, how you could improve yourself. So that is immense practice, because we have proper candidate instructions running to 2-3 pages with a lot of information, exactly like we have in the exams. So that's how we can help you. And anything that you want to ask, if you want to tag your mentor for anything, we are there always to help you. And we do have a very good library, which has n number of templates, n number of cases, all exam tested scenarios, so that you don't need to go hunting. So they're all under one roof. That is the biggest advantage that we have. And there is a special offer going on, so you can talk to the salespeople, and they're going to come back to you with a lot more information regarding that, where they are going to give you a lot of discount on the particular packages. Okay. Any questions that anyone wants to ask me? Okay, so I'm going to end there. Thank you, everybody, for joining in. I hope that we are going to see a lot of these names in our groups as well. Till then, please, as I said, please start immediate practicing from tomorrow morning. Okay, whenever you get time, catch hold of anybody, the nurse, the security guard, anyone who can speak 2 lines of English. It doesn't matter. The English doesn't have to be good. Okay. In case you do have a colleague who's also giving, then of course you're at a better position. Thank you so much for participating in this. And I hope this was useful to you. Good night, guys, and God bless. Please keep studying, keep practicing. Thank you.